talking about it, but I think Ben had stepped out of the room. Can we have him do under future?
God, this agenda's so tight, it's very legally perfect. There's nowhere to hedge.
I will call the meeting of the Wausau Placing Task Force. Couldn't attend, and I don't see Kaylee, but otherwise everyone, we have a quorum present. What are the wishes relative to the minutes of the April 21st meeting, which were distributed with the packet?
It's Will Harris. I'll make a motion to approve.
Moved by Will Harris. Is there a second? Second by Pat Peckham. Any discussion? If not, all those in favor of approval of the minutes will signify by saying aye.
Aye.
Opposed, no. That motion carries. Next, we'll go on to a presentation by the illustrious member of the Wausau Police and Fire Commission and this task force, Michael Loy, CEO of North Central Healthcare.
Okay, after that introduction, it's all downhill from here. All right, just let me make sure I got everything going here. Okay, that's not what I want to do. Okay. Can everybody on the task force see this? I'm assuming you're looking here, right? Okay, if it's okay, I'm going to drop this. I'm fully vaccinated distance-wise, okay? So I'll speak here into this. Otherwise, you might not hear me. I tend to be very low-toned. All right, it's a privilege to be able to give this presentation. I feel like I've been giving this presentation several times over the last several weeks because it's a hot topic now, as always, but certainly relevant to the work of this task force. And I was not a professional or an expert in any of these matters before I went to North Central Healthcare, but in the last 6 years I've picked up a few things, and looking at this at a very macro level, I have a lot of different perspectives about our emergency mental health services, and hope to share several of those with you this evening. First, emergency mental health services is really where law enforcement and the mental health system of any community cross over. This is where we interact the most, and certainly in the most critical situations. I'd like to start this presentation, with the point that mental illness is not a crime. Addiction is not a crime. People with mental illness and addiction commit crimes, and untreated mental illness shows up all the time in the criminal justice system. And that's what we're faced with. And I think a fair amount of that is a result of broader policy issues that, are decades old, really starting in what I would classify as the 1950s. In the 1950s, the first pharmaceutical drug was made available for psychiatric issues, as well as a predominant belief that the United States needed to deinstitutionalize the psychiatric facilities across the nation due to poor sanitary conditions and poor quality of care. All justified, but there was what I would classify as a overreaction to that, and essentially moving people into the communities. And as a result of the Mental Health Act by President Kennedy, the predominant belief system was that community mental health centers were the future for mental health services across the nation. The problem with that is that the 70s came and the federal funding started to dry up. And the full dream and proposition of community mental health centers never got the adequate funding that it needed to. So therefore, untreated mental illness and addictions got more predominant later, started to show up more predominantly in the criminal justice system. And that is unfortunate, and certainly part of the reason why we're dealing with some of the issues that we're dealing with today. All right. Let's see here. Okay, now I'm driving. First thing I want to talk about is county responsibility. So who is fundamentally responsible for the emergency mental health system before we get to how we interact in that? The primary responsibility for the emergency mental health system and the community support programs that we provide at North Central Healthcare is a authority given to the county boards, delegated responsibility from the state of Wisconsin, where counties have the primary responsibility for the well-being, treatment, and care of the mentally ill, developmentally disabled, alcoholic, and other drug-dependent citizens residing within its county, and for ensuring that those individuals in need of such emergency services found within its county receive immediate emergency services. The statutes are quite long, but that fundamental responsibility around emergency mental health care is what drives everything. In the state of Wisconsin, what is unique is that we have a very county-based mental health system, and there's a few regional exceptions. But if you take all of those together between the regional and the individual county systems, there are 68 different ways that the state of Wisconsin provides emergency mental health systems, which is a difficult thing for law enforcement and healthcare systems in interacting with that. And so that primary responsibility is constructed in many different ways. Primarily, we'll talk about the emergency services, and there's two different facets. There's the basic level that all counties have to fulfill, and then there's a secondary option for counties to provide more extensive services if they so choose, and avail themselves of additional funding if they so choose to do that. Outside of that, the mental health system in a community is based on the available resources. And a community can decide how they want to deploy those resources and how they want to deploy and design their entire community mental health system, which again varies greatly. So a key policy decision of the counties that represent my organization, North Central Healthcare, and what we do going forward and what we offer to the community is really around what mix of programs and services should we deploy, and I see that as trying to accomplish a couple of different things. First is one, to minimize the county liability. If counties did nothing other than the emergency mental health services that they're required to do, they would ultimately be required to pay for institutionalization or care at the state institutes, which could be very, very expensive if they don't work to provide programs and services to keep individuals out of the institutions and out of the criminal justice system, and certainly in the community and independent. So one of the major policy considerations is to minimize that liability, because it is expensive. A inpatient stay of 10 days for a county is well over $10,000. So it racks up pretty fast, and there's a lot of dollars that are spent at the state institutes. The second policy item gets at maximizing other funding sources for other programs and services. And then lastly, to effectively manage residents with severe and persistent mental illness and addictions outside of institutions and the criminal justice system. That is the major policy issue for us, to try to effectively do that in the least restrictive manner possible, and certainly focusing on recovery and independence in the community. So I want to walk you through the first basic level of emergency services that all counties are required to provide. There is not a competitor. Counties provide the service all across the state, and they are the core and in many communities the only mental health resources. Essentially, DHS 34 stipulates emergency mental health programs. It requires every county to provide or contract to provide. There are several counties that contract with emergency crisis services to comply with this section. And then the emergencies mental health services means a coordinated system of mental health services which provide an immediate response to assist a person experiencing mental illness. And so a lot of counties will do that telephonically and then dispatch on an on-call basis if necessary, if they have to do that. But not a lot of counties invest resources into that. In a basic emergency mental health service program, we need to provide immediate evaluation of mental health care to persons experiencing a mental health crisis. We have to make services available, emergency services within the county's outpatient program or mental health day treatment program. So what a lot of counties will do in compliance with this statute is they will work with law enforcement or work with the individual to keep them in their home and then connect them with services the next business day versus immediately. And sometimes that can obviously be problematic if they have a false sense of security in doing so. And then ultimately it needs to be organized with assigned responsibility, staff, and resources so that it's a clearly identifiable program. So every county has to have a crisis services number and a crisis services department, even though it may be embedded in other programs and services. Emergency services shall be available 24 hours a day. That means 24-hour phone, telephonic services, and then provide for face-to-face contact. Again, that can be a function of the outpatient department, and then have the capability of making home visits. That doesn't say anything about how timely those home visits are. They just have to have the capability of doing that at some point in the care. Now, the second iteration of emergency mental health services program, the next upping the ante, if you will, and I'm not sure what the exact mix is across the state of Wisconsin about which counties do the basic level and which ones do the more extensive services, but we do the more extensive services, and essentially the standards in this phase is or allows counties to be able to bill Medicaid for some of their services. And when you do that, it's a 60% reimbursement rate from the federal government. The state does not reimburse in that, although there are some grants and block-based county allocations that do come back, but it is predominantly funded, the gap is funded through the county tax levy. There is a policy debate that often happens about whether or not we should charge individuals for emergency crisis services. I think it's a worthwhile conversation to have around that, but essentially even the state discourages counties from doing that because in doing so then you lose out on all the access to the Medicare or Medicaid dollars from the federal government, and that would be substantial to our community. So that is an opportunity for us to look at as a community at some point if the county were willing to fund that significant outlay all in of itself. But in addition to everything I covered before, we have to have a written plan for coordinating emergency mental health services with the following objectives, which you can see outlined there. And it's really about linking people up and making sure services are available 24 hours a day. So again, you see the 24-hour crisis telephone services. You have to deploy mobile crisis in this case, and that means going out, available on really demand. But it is limited. It's not full 24-hour mobile crisis. It's 8 hours a day, 7 days a week at the peak service times, which for most crisis services programs are going to be late afternoon to the probably midnight hour. And a lot of crisis programs will staff that way. We at North Central Healthcare do deploy full 24/7 mobile crisis teams. And so we have that around the clock. You have to offer walk-in services 8 hours a day, 5 days a week. Again, at North Central Healthcare, we have the crisis center where anybody can walk up to 24 hours a day, and then have access to short-term voluntary or involuntary hospital care, which all counties do through the virtue of being or having access to the state institutes. But at North Central Healthcare, we have a 16-bed inpatient adult unit and now a 8-bed youth unit, which allows us to have that right on site, which is a huge advantage. And then 24-hour linkage and coordination services. Essentially, this is what our crisis team does. They'll do the assessments, and if it's deemed that they have the necessary supports and are not a danger to themselves or others, we will refer them to linkage and coordination services following the crisis assessment if we deem that to be appropriate in that situation. So in terms of organizing mental health services into kind of a operative discussion today, there's really 4 elements that I'd like to talk about. One is emergency detention. The second is around settlements and commitment orders, and that's a really heavily legal process. The third is around voluntary treatment, and the last is around addiction services, alcohol, and other drugs. When we talk about emergency mental health services, it's important for you to see the distinction that it doesn't say emergency mental health and addiction services. This is a conversation I have a lot with people in the community that assume that if somebody with an addiction shows up at the crisis center and wants to get help, that we will admit them into our programs and services. That is not, in fact, the case. And the standards for emergency detention and commitments and settlement agreements on addiction alone is a very tough standard for us to be able to enforce. And as it relates to emergency detention, if you think about the continuum, I think with alcohol, it's a lot more easily identifiable because you can physiologically test for that when they're getting to a point where they could have serious medical and physical reactions. When you get into other drugs, there certainly is the chance for overdose, but for us to be able to tell the level of toxicity or the risks of the person, I mean, that's subjective to each person. And the fact that they could go out and reuse and overdose doesn't necessarily rise to the level of dangerousness. And so that is a really complex nuance, I think, to the emergency mental health system. And it is a huge factor in what we're dealing with today because obviously addiction is a very, very present thing in our community. And what I'll tell you is that we deal with complex patients that it's pretty standard course of treatment to deal with somebody that has schizophrenia. But when you start to deal with somebody that is schizophrenic that starts to choose to use meth, it is a completely different patient, and it is a completely rewrite of the game in terms of trying to work with that individual. So those are the kind of people that we have the biggest challenges with the dual diagnoses, and certainly methamphetamine is a very predominant drug in addition to opiates. So what constitutes an emergency? There is a standard legally for that to happen. That is that the individual has a mental illness. That's pretty easy to identify or be able to substantiate. The second is that they are a danger to themselves or others. And third, their illness is treatable. And I'm going to talk about all 3 of these elements as we go forward, but it's important for you to understand that the state of Wisconsin necessitates the involvement of law enforcement along with a clinical person. That is the law in Wisconsin. You have to have both because there is both a legal standard in emergency crisis services, and then there's also the medical necessity or the clinical standard. And you have to have both sign off on the emergency detention and ultimately any commitment or settlement agreement for continued involuntary treatment. And the reason for the legal standard is that we're fundamentally removing somebody's civil rights. It's a civil process. They're taken into custody. And that is a very powerful and important thing that we are choosing to do, and ultimately we need a sworn law enforcement to be able to do that. The second component, of course, is around medical necessity, and that's a clinical standard that our team interacts with. We do have physicians available 24 hours a day to be able to consult with and ultimately coordinate the admission, but you have to have both. Ultimately, the priorities in any emergency is fundamentally first safety, and I would suggest that that is another reason that law enforcement needs to be involved because we need to make sure that our staff is safe and that they are charged with ensuring public safety. In a lot of these situations, that is a cause for concern, especially when you're dealing with somebody that is potentially a harm to others. So we want to ensure safety, and our goal is always voluntary treatment, and the statutes support that. The standard for involuntary care in an institution is pretty high, and there's a lot of risk from a civil rights due process standpoint, and certainly don't want to infringe on those rights, and so the standard to be able to reach that level is pretty significant. and certainly is justified in a lot of cases, but it's something we want to be thoughtful about. And the goal is always voluntary treatment, because long-term recovery is highly correlated to somebody's willingness to engage in treatment. We can force somebody to come in voluntarily. At some point, that process will stabilize, and then if they're not interested in long-term recovery, it's going to be kind of a revolving cycle for that individual in our organization. So I talked about the 3 standards, somebody having a diagnosable mental illness, and then it being treatable, and then really predominantly the issue that we're dealing with is dangerousness. And so you'll hear this often, are they a danger to themselves and others? That's the plain language substantiation of a mental health emergency. And there are 4 standards in the statutes that we typically use in this process. First is that there's a substantial probability of physical harm to himself or herself. And then the second is a substantial probability of physical harm to other persons as manifested by evidence of recent homicidal or other violent behavior. The third standard is a substantial probability of physical impairment or injury to himself or herself due to impaired judgment as manifested by evidence of a recent act or omission. These third and fourth standards are much higher standards and harder to substantiate. And then the fourth starts to fold in the addiction piece, which is that behavior manifested by a recent act or omission that due to mental illness or drug dependency, the individual is unable to satisfy basic needs for nourishment, medical care, shelter, or safety without prompt and adequate treatment, so that a substantial probability exists for death, serious injury, or debilitation. This is a tough standard to meet. You can argue that there are several people every day that could probably rise to this level, but again, we're dealing with somebody's civil rights, and there's a lot of protections for somebody's individual liberties not to be infringed upon in this process, and disability rights folks that support it. And that's all important, but it does sometimes cause frustration in entering the system. So the other major issue, we get to the point where dangerousness is the predominant issue of whether or not somebody's taken into that emergency detention or put on a commitment or settlement agreement. So the determination has been made, they hit the 3 criteria, they need inpatient psychiatric care, and upon that decision, the sign off by the law enforcement agent and the clinical professional, that individual then is taken into custody. They are taken into custody often in the squad car. We've made great inroads to, in most situations, not actually have to handcuff an individual, and that's been a great success over the last several years, if at all possible, again, taking safety into consideration. But ultimately, law enforcement transports that individual to either our facility, but most often they transport them to the emergency room. And I can tell you that 90% of the time that's unnecessary, but it's an important part of the process for us right now in the way that we're organized, because we have to ensure that the medical condition is not being caused by a physical manifestation of a medical issue that happens. Psychiatric secondary manifestations of symptoms as a result of a medical condition happen all the time. And we need to make sure that the medical condition isn't driving the psychiatric issue. That is fundamentally important, because our facility is a freestanding psychiatric facility, as is most psychiatric facilities, which means that we do not have the medical capacity to treat an individual for some of the medical conditions that could be causing the psychiatric issue. So this causes a lot of angst in the partnership with law enforcement, because oftentimes they'll look at an individual and that they look all right. We know this person, and that individual is still sent for medical clearance, and that's the call of the admitting physician at our organization. And a lot of that is kind of CYA medicine. Obviously, they're taking on the liability of bringing somebody in, and they want to make sure that they bring somebody in and onto a unit that they feel is medically stable, so that they can address the predominant issue, which is the psychiatric issue at that point. So that's why that is done, and in many communities it can be hours. There are reports across the nation where individuals in emergency rooms spend days waiting for access to a psychiatric facility. Here in our community, we've gotten that down about as efficient as you can get it, but essentially the law enforcement official has to transport and stay with the individual all the way until they receive to the treatment facility where we then take over custody. But up until that point, we do not take on custody until we have been reassured or in our own judgment feel that they are medically stable. We can make that call. But if the emergency room determines that they're medically stable, we can agree with them. And if we agree, then we've accepted the admission and the transfer. And that's where EMTALA comes in. The hospital can't release somebody until we say that we're ready to accept them. And I can tell you that this is the other major area of conflict, which is that not all doctors agree on the same protocol for what needs to be or is constituted as medical clearance. And so we may run a battery of tests under a normal protocol, and then the admitting physician says, I want this test run. And that will slow down and start the process over in many respects. That is where things get frustrating because we have a standard protocol set. We generally know our 2 ERs pretty well, but then if we're sending somebody to another state institute for various reasons, like Winnebago, they might have a whole other host of testing protocols that send somebody back to the ED. Yes, Pat?
Sorry to interrupt, but you've mentioned several times emergency commitments and settlements. I know what a commitment is, but I don't know what a settlement is.
Yeah, I'll get to that distinction in just a second.
Very good, thank you.
You bet. So that's one of those are the primary driving reasons in medical clearance. I can tell you that's not the case all over the state. In Milwaukee County, they are much more successful in that in the partnership with the hospitals and have more resources available. They actually have a psychiatrist on site 24 hours a day, and because that psychiatrist can actually lay eyes on the individual, they are a physician, they're a doctor. So they can lay eyes on that individual and they feel a lot more comfortable admitting them once they get an ability to kind of observe and do a little bit of screenings. So in Milwaukee County, it's quite the opposite. About 90% of medical clearance happens actually at the treatment facility. And that's the goal, ultimately, what we're trying to get to. And I think that we can do that here in a relatively short order. The other question we get is, why does law enforcement have to transport the individual? The answer is they don't. They can contract for that, but ultimately is their responsibility, again, for safety reasons, but then also for the fact that they have taken somebody into custody, and we do not take over that custody until that individual is received at our treatment facility. We do, at times, offer, for low-risk situations, transportation on behalf of law enforcement, which gets them back on the road, which is ultimately the biggest concern, is that any of these processes keep law enforcement off of the streets in our community and not doing their core safety responsibilities. Okay, background on settlement agreements and commitments. So following an emergency detention, so an individual has been deemed to be a risk to themselves or others or any of those 4 standards we talked about, a probable cause hearing must be held within 72 hours. Again, we're revoking somebody's civil rights and involuntarily committing them to treatment. If they accept to come into treatment through this process and the interaction on the community, and they do so voluntarily, we don't need to go through any of this process. But if they are deemed to be a danger to themselves or others and have the other 2 criteria, the law enforcement and the clinical individual agree, and they are then brought into the emergency detention situation. There are other ways that people can move into emergency detention through 3-party petitions and other different processes to get somebody in for emergency treatment, but most cases it's a 5115, which is the statutory reference for the ability to revoke somebody's civil rights and then bring them into involuntary treatment. Once that's done, the clock starts ticking from the time the officer takes the individual into custody. And within 72 hours, we have to observe the individual and then be able to diagnose and recommend clinically whether or not continued involuntary treatment is necessary. And ultimately, that will go into a court proceeding with the corporation counsel in each of the 3 counties that we have. So again, that's brought before a judge, and that determination is made. The court must decide that if it's reasonably believed that the 3 standards are met, an agreement can be made, so this is a settlement agreement piece, between the individual that was detained and the county, that the individual will voluntarily seek treatment on this 90-day agreement. So essentially what it does is it will it's kind of a blend between voluntary treatment and the full commitment order, where it's saying, okay, we need to do something. We don't necessarily feel great about letting you just do this completely voluntarily. We're going to have some stipulations, and then when that's done, and made between the two parties. The goal is, again, to hopefully get them voluntarily engaged in treatment, and then once they enter that treatment, if they fail to comply with that agreement, then the court can petition to move that to a commitment, which is much more stringent in terms of the requirements of the individual, and gives the county more authority in moving somebody to more restrictive than the settlement agreement in of itself.
Michael, are those automatically 90 days, or is there a variable?
They're 90 days. And they can be renewable, and we do renew settlement agreements from time to time. And it's, again, that happy medium between voluntary and involuntary care. Commitments on a whole other order include recommendations for medication treatment that require longer-term services and supervision. The initial commitment is 6 months, and subsequent commitments cannot exceed 1 year. And again, this legal choice that we're making is very, very significant. And the commitment to treat, especially in the inpatient facility, is as significant as the commitment to confine somebody, so jail. I mean, it is that significant legally. And we take that seriously. But in our community, we are on average managing about 250 commitments and settlement agreements at any given time. So there are a fair amount of people that are on longer-term commitments that have been involved in our system of care for many, many years. And they're the most vulnerable and severely mentally ill people in our community. So what happens when somebody is put on a commitment? Essentially, they are committed to our organization. They statutorily are committed to the county department under 5142. And if you jump down to number 5, the board to which the patient is committed shall provide the least restrictive treatment alternative appropriate to the patient's needs and movement through all appropriate necessary treatments components to assure a continuity of care. So essentially, even though we have a commitment, we have a legal duty and obligation to care for somebody in the least restrictive way possible. So that means that if we can successfully minimize their threat to themselves or others by having them be compliant in outpatient treatment, that's sufficient enough. Even though we have the ability to bring them into the hospital, we need to orientate towards outpatient. And I think the whole idea around what is compliance with a commitment order is not a true black-white kind of demarcated line, and it changes in every situation. And I think it's important that, you know, within this understanding of what a commitment is that individuals not committed for treatment, but they are committed to North Central Health Care for treatment. So we are now responsible for obtaining all access to treatment for that individual, whether that's through a contract or through our own programs and services. We are responsible for keeping that person stable in our community. And again, this is our most vulnerable and severely mentally ill individuals in our community. So when we're talking about, I would say, predominantly commitments, again, because settlement agreements either go, one of 3 ways. The person gets better or well enough where they no longer is necessary, or they maintain on it because they're complying, but they're not quite ready to get off of it, or they're not complying and they go to a full commitment order. I mean, that's the 3 choices. So when we talk about how we manage commitment orders, I think that's the most significant policy decision for us. And the opportunity for North Central Healthcare is to find a more clear and consistent way for moving people through commitments, because noncompliance is a very real thing with somebody under a commitment order. And just because somebody is noncompliant in a pure sense with their treatment order doesn't mean we just pull them off the street and put them in the inpatient unit. We have to give them the opportunity to engage in treatment, and again, the dispositions towards least restrictive. And sometimes this can be frustrating, especially to individuals in the criminal justice system who under probation and parole are said to basically that you are to comply with treatment. And the minute you stop complying, therefore, you are violating your commitment order, and we should put you back in inpatient. That doesn't get to the level of whether or not clinically that's appropriate. So they may have violated or not be compliant, but the individual, is not rising to the level of being such a danger to themselves or other that necessarily that they need to be brought to that restrictive form of care. So key policy questions for us are, what is noncompliance? What do we do with people that are non-compliant? So you get a call from somebody from, let's say, probation and parole, and somebody's not are violating their commitment order, but they're not in a position where we need to move them to a more restrictive. Then what? What do you do with them? And this is especially challenging around addiction, and then there's this whole other element of sometimes treatability of individuals reaches a saturation point, and there's no longer a modifiable mental health issue. I'll get to those things again here in just a second. In terms of background on our statistics, these are the commitment and settlement agreement and emergency detention statistics for our community in 2020. So taking you through the slide, and I know it might be difficult to read it, but the grand total in 2020 in terms of emergency detentions were 331. Of that 331, about a third was, just over a third, was Wausau PD in of itself. The remainder comprised other departments within our county. The Sheriff's Department, of course, was the second. So together, Marathon County Sheriff's Department and Wausau PD are about 2/3 of the emergency detentions. Those are our two key partners. And then you can see the number of other individuals. So out of 331 emergency detentions in 2020, if you go over to the right, those move into probable cause hearings. Out of the 331, 165 resulted in settlement agreements. 96, so almost a fourth, I guess it'd be about a fourth of the emergency detentions were dismissed, meaning after 72 hours they were dismissed to go home, and so there was no longer that standard being met. 59 resulted in final hearings, and then if you jump down out of the final hearings, there were some that were moved to settlement agreements, some that were dismissed, and then certainly some settlement agreements were revoked. But ultimately down there you can see the number of people that we recommitted last year. So these are not the new commitments, but recommitments, 177. So there's a lot of activity related to commitments and settlement agreements. And if you look at these numbers, about once per day somebody is detained in Marathon County for a mental illness. And that's pretty significant.
Are those individuals or are there multiple?
Could be multiple.
Do you have any idea how many multiple commitments there are or emergency?
There wouldn't be multiple commitments, but multiple
Or
emergency detentions.
detentions.
I don't have an idea of what that would be. So again, getting back to this idea of noncompliance with a commitment order, and again, this is a struggle with our partners in the community. Simply put, noncompliance is a failure to comply with the treatment plan. Again, this question of does it necessitate a move to more restrictive, and is that when somebody doesn't show for an appointment? I can tell you that 1 out of every 5 of our outpatient appointments no-shows, so 20% on average. And those are individuals that have, their insurance, their transportation, reminders, everything is set up for them to be successful, and we still have 1 out of every 5 no-show. And so that's a very real thing. It's a very real thing for individuals in recovery. How about if they don't return a call, if they don't fill a prescription, or when they relapse and use alcohol or other illicit drugs? All those things could be noncompliance, could move somebody more restrictive, and it's much clearer for us when a dangerousness threshold is reached. That's the clearest piece of this, is if they're a harm to themselves or others, then we can really cross that and move somebody more to restrictive. But when that's not the case, when that's not been broached, then it's a little bit more struggle. So a couple other key distinctions. If someone's on a commitment and interacts with our staff are trained to assess that dangerousness element, and they do a good job of that. But the problem that I think is fundamentally the challenge for us is again, what do you do when somebody's not imminently a danger to themselves or others, or there's not concurrence between law enforcement and the clinical professional? That does happen, but is non-compliant with their treatment in some degree. So again, it's that gray space of then what? Somebody comes over to North Central Healthcare, we'll go with an addiction. So they've got an underlying mental illness, they have an addiction, they show up at the warming shelter, the warming shelter talks with them, and that individual says, I really want to get better, I really want to get access to treatment. And so they send them to North Central Healthcare. They send them to North Central Healthcare, and a crisis staff member is going to assess them for that criteria for treatment. But they're there saying, I want to get better. I want to get better, I want to engage in treatment. and they haven't then, in maybe essence, crossed that threshold. And so we connect them with resources, and then we send them away. And then the message is, well, I got sent away from North Central Healthcare. Well, again, if you're following along the presentation, that's the goal. The goal is to get individuals voluntarily into treatment, and then to do it on an outpatient in a less restrictive form of care. But we all know the minute that that individual walks away from the facility is the most challenging time in that recovery, and that they're most at risk. But that is the reality of the system that we're dealing with in its current state today. And again, as it relates to addiction, many people believe that our crisis services is orientated towards connecting people to addiction services. Our crisis services is orientated towards mental health crises. And I know that's a challenge for people to understand, but our crisis staff are not required by state law, and is not currently part of our programming to teach them to assess for substance use needs. They are purely looking at mental health crises. That is changing. It's changing at the state level, and I think that's a good thing. But fundamentally, that is not the system that it is today, and something that we're going to, and I'll talk more about that at the end. The other related issue that we have, I think, is it deals with law enforcement. This is particularly important, I think, for the task force, and just so you understand the interaction, is when somebody is deemed to be non-compliant, who is responsible for moving them to more restrictive? You know, clearly our crisis staff have the authority and the ability to do that. But in doing that and revoking somebody's right to be independent in the community and move them to more restrictive, so involuntary care in our inpatient unit, obviously that's a risk for somebody to be agitated, aggressive, upset. And so that's often where we need to rely on law enforcement to come in and basically work with us to get them back into that involuntary, more restrictive level of care. So that is a partnership, but you know, fundamentally we're responsible for that. The other concern is treatability. Sometimes our physicians get frustrated because people keep coming in and out, and they are struggling with somebody not wanting to engage in treatment and treatment not being successful at some point. So again, the standard is the same. And I think when you get to the idea of treatability, the county has the ability to release somebody from a commitment order or settlement agreement, or to release them from the emergency detention if they don't, that clinician doesn't feel like they hit the criteria. Clearly, this is a frustration. If law enforcement has been dealing with somebody out in the public, thinks they should be detained, but clinically we say they shouldn't be, or it's an individual that you know, comes in and out of our services, and at times you know, we'll get to a point where the treatment is not actually modifying the mental condition. So when somebody presents, the mental illness has to be modifiable through treatment or modifiable through medication adjustments. If it's not modifiable and it's behavioral in nature, sometimes a physician will say this isn't treatable. And clearly, then we get to that same question of, well, then what? And obviously, that person was in behaviorally for some reason out in the community. So that was an overview of the emergency mental health system, and I think it's important for this task force to understand the nature, the scope, the authorities, and responsibilities in that system, to understand not only what we're obligated or structured to do, but then also how law enforcement intersects, and some of those pain points where clearly it's necessary that they're part of the process given the gravity of what we're doing. But we always try to take law enforcement out of the picture as soon as possible once safety has been established and we can take over. That's not always possible, but that is our goal. So as I shift in the second half of this presentation, I want to talk about, you know, we've covered what we are today. What are we going to be in the future? What are we working towards? What have we been working towards over the last 3 or 4 years? And certainly what's guiding that decision. One of the national standards that we've been using as an organization, and the state of Wisconsin's using, is the Crisis Now framework. Crisis and emergency services is an issue everywhere. That certainly is across the state of Wisconsin. But essentially, best practices suggest that we should all have a regional or statewide crisis call center. We have that, check. We've had that for a number of years. A centrally deployed mobile crisis on a 24/7 basis, check. We have that here in our community. Residential crisis stabilization programs, we now, and have had actually, but now have a new facility for this. We have a crisis stabilization facility on our campus. That is a voluntary unit for somebody to come in and spend up to 28 days as an alternative to hospitalization or a step down from hospitalization. We have that for adults, and very shortly we're going to actually have that for youth. So we'll have both inpatient care and step down or alternative care to hospitalization in our stabilization facilities. That is unique. Not a lot of communities in the state of Wisconsin have that. So check on that one. And then essential crisis care principles and practices to have a recovery orientation, which means that both recovery and mental illness and addiction is lifelong, and people ebb and flow in and out of recovery. And so understanding that when people come to us, the expectation can't just be, we'll fix them. We need to walk with them, and certainly recovery is a lifelong journey. Trauma-informed care is a very important piece of how we interact, assuming not what's wrong with you, but what's happened to you in your life that's caused trauma. Mental illness and addiction are often secondary to trauma in an individual's life, and that is what pushes them into their illness or their addiction. We have a huge opportunity to expand the use of peer staff. I can tell you some of the best practitioners that we have are individuals that are in recovery or had a mental illness themselves and found recovery. That relatability and the ability to connect with people is powerful. And the ability to use peer supports is important for us in our services, but it's also sometimes unreliable because when somebody's in recovery, sometimes they fall out of recovery, and you have that individual working with others in recovery, and that's a very vulnerable situation, but it is very important to offer that. The fourth element is commitment to zero suicide. That is something we do in our organization. In Marathon County, whether they are a patient of ours or not, every suicide in Marathon County is reviewed by our organization to understand what we could have done differently to either engage them in services, or if they were engaged in services, what potentially have we missed, or what could we have done better to be been able to serve those individuals. We deal with suicide, dozens of suicide assessments every day. We do about 15 to 20 crisis assessments a day in our emergency services, but our staff and all of our programs and services are regularly doing suicide assessments. And it's often the ones that you would least expect it that actually attempt and complete suicides. So we look at every single one, and we have a very committed process internally of looking at every suicide and trying to get to zero as a community. A strong commitment to safety for consumers and staff. Again, that's safety when they're on the site and interacting with them in the community, and then the importance of the collaboration with law enforcement. And we've got wonderful partners here in Marathon County that have been long invested in improving crisis services. In many cases, law enforcement's been some of the impetus and pushing into improvements in our crisis services because of how much they deal with it in the community and how much we both need each other. So there's been a lot of conversation across the state about what can we do to fix the state of Wisconsin's emergency and mental health services and the response. And there's a whole host of logos on this next slide of a group that came together to provide recommendations to reform the state's crisis mental health response. So on here you see the Department of Justice, a number of law enforcement affiliated agencies, the Department of Health Services, the Counties Association, the Wisconsin Psychiatric Association, the Wisconsin Hospitals Associations, NAMI, a very diverse and comprehensive group of people that have been talking about what can we do collectively. And this group put out a whole host of recommendations that I think are important for us to consider as a task force and how they impact our interactions. There's two key components. One is to divert a larger share of cases away from emergency detention. And the second is the process and capacity for EDs must be improved. There are 13 total recommendations, but all need legislative or budget approval to be accomplished. The first is regional crisis stabilization facilities, so options for voluntary and involuntary options, and providing more freestanding psychiatric emergency rooms and inpatient hospital units. Again, we have those resources here in our community, so we are unique in that, but many, many communities do not have that. Therefore, law enforcement transports them to state institutes, which can be a whole shift for a law enforcement agent in many communities in the state of Wisconsin. Peer support respite centers are home-like environments. So think of this as a house that is a peer supports are just populated at, and people can drop in, and if they're interested in recovery, they can just talk about how to access services. This is something that's been very successful in Milwaukee. We have the Community Corner Clubhouse, which in some ways is like this, but it's not exactly what this is. This is completely peer-run, and it's a place for individuals to just start that process. The third recommendation was on mental health mobile crisis teams, CART. We're very familiar with CART in our community, so I want to talk a little bit, what about CART? These are some statistics that I've gotten recently from the Wausau PD relative to CART. CART has been very successful in our community, and a number of communities in the state of Wisconsin are pursuing this. Essentially, as you know, we're pairing a full-time law enforcement professional with a full-time crisis staff member. They work as a team every single day. You can see some statistics here in the number of responses. So on the left, in 2019 was when the first Superion, the new computer-aided dispatch system, was available for a full year. So on here you can see the number of calls for services for mental health related calls for services, welfare checks, juvenile disturbances, the number of detentions by agency, and then the number of CART responses. And so what you've seen over the last 3 years is the number of mental health call for services have gone down. Part of that's because the CART teams are proactively following up with individuals that they know that they're been part of calls for services in the past or recently. But then on the right, you can also see the number of CART responses just growing in terms of being able to be the first line of response to these types of calls, which I think is incredibly important. And I think if you offer CART at night, because it's only available during the day, during Monday through Friday, if we expanded it to the nighttime and the weekends, we would be able to probably carve up almost a whole other half of this, I would imagine. I mean, it would be pretty significant in terms of what they could do in responding to these calls for services. They're a very vital resource and very successful in what they're doing. And ultimately, you can see the number of emergency detentions going down. We've seen that in our hospital volume as well. So they're more active, less emergency detentions. That's exactly what we're trying to achieve. This year, we kind of see very similar responses. We should be right in the middle of the pack in terms of the 5115s over the last 3 years, and their number of responses should be a record year if it continues on the path that it's on. And then also, there's an important distinction about where 5115s originate from. So this slide here on the right, if you look between the difference of community versus facility in 2021 year to date, the first number, so 34 of our 5115s, our emergency detentions, were community in nature. So we intervened out in the community at someone's home or to school, and then the detention process was initiated. But almost half of the total detentions, so 25 of them, were initiated in institutions. So whether that's the jail or at North Central Healthcare, if we need to transport somebody or convert somebody, that means that somebody was already engaged or part of our system and had to be moved to a more restrictive level of care. So only 34 community-based detentions have occurred in the first quarter of this year. And I think that's an important data point for us to continue to look at as well. Continuing with the recommendations, regional crisis assessment services, essentially just being able to do more on site. Think of this as a psych ED, and I'll come back to that idea here at the end. Enhanced community-based treatment for suicidality. We have a fundamental problem with Medicaid rates reimbursing adequately for mental health care, and mental health parity in the state of Wisconsin and nationally is still a far cry from true parity. And there's a lot of work that needs to be done with that. But focusing on suicide prevention and DBT for bipolar individuals is certainly really a great, and personality disorders is really a great service that we've been expanding on. Crisis intervention training is an important investment both the Wausau PD and the Sheriff's Department have made with their law enforcement professionals that teaches law enforcement officials about how to respond more effectively in crisis situations. And that has made a dramatic positive impact on our interaction out in the community. We need to continue to do that and make that universally available. Additional mental health bed space is definitely needed. This idea of deinstitutionalize the state institutes. Medical clearance, there's this work being done between Wisconsin emergency room physicians and the American Psychiatric Association or the Wisconsin Psychiatric Association to come up with a standard protocol for pre-admission testing. So that it's standard at all emergency rooms and at all facilities across the state of Wisconsin. The funny thing is that physicians are all, have different preferences, so that's going to be the barrier. It's not that we can agree on what's the standard protocol, the barrier is going to be getting them to all consistently apply it, because they have the prerogative not to. It would be completely voluntary. Bed Tractor, essentially they want to have a database that tracks available psychiatric beds in the state of Wisconsin. I think the belief is that we could locate beds faster and therefore spend less time out in the process of trying to get somebody into a treatment facility. I don't think that this is going to be as effective as they think it will be, but it would certainly bring more data to the equation of challenges we have in the state. Expanding telemedicine for use in EDs, I think this is important and especially salient for out in the community, enabling officers to have video capabilities so that we can lay eyes on somebody. That would probably help a lot in a number of situations when we're doing those assessments. I don't know what I did there. And the last two are really kind of general. One is transport across state lines. This is important for border communities, not so much for us. And then ongoing discussions and promotion of regional innovation. So again, this broad group got together, put forth a number of policy recommendations on what we need to do to improve the state mental health system. And then from there, there's also been some work being done on the 5115 process in terms of the 72-hour clock. There's a Senate bill that's currently going through right now that I think is highly advantageous for our communities. So if you remember earlier, once somebody's taken into custody, the 72-hour clock starts going immediately. Sometimes that's problematic if somebody has a lot of medical conditions. So in an instance of somebody that has attempted a suicide and then now is in critical care, they would go into the hospital and the 72-hour time frame would elapse. And therefore that we would have to start the whole ED process over. And the criteria for being able to get to that dangerousness is tougher because are they dangerous right now? No. But is the reason why they're in here because they were a danger to themselves? Yes. This would correct that issue. And essentially the 72-hour clock would start once the receiving treatment facility obtains the individual, which is hugely helpful for us for observation and treatment and evaluation, as well as for the legal process to run its course. So these recommendations from that group go into the state budget. There's a lot of conversation happening relative to the state budget, and you can see some of these priorities in reforming the system showed up with funding. Essentially, the budget, if approved, it has several provisions in it that we hope will get bipartisan support. One is regional crisis centers. Again, we have this today, but this would provide better funding for us. And these are two new centers that will provide a continuum of care that will improve stabilization and treatment services in communities and support local mobile crisis units. Again, we're the model for this. We're doing it, but this would provide some additional funding. The second is around those regional crisis stabilization facilities. Again, we're just opening our new facility next week. We'll be one of the first and certainly have a model for the rest of the state to look at. The picture below is of me and the interim DHS secretary that was here last week visiting North Central Healthcare. She was conducting a roundtable, but really attaching what's happening in the budget to what we're doing at North Central Healthcare as the model, and certainly going to be out in front for some of the state funding, but this will help support those programs. And then third, collaboration with law enforcement. This is to provide more crisis intervention training across the state. This would be very helpful for us to continue to do this throughout the criminal justice system, but specifically through law enforcement. This is a very important budget provision for us to support. And then I'll wrap up and just talk future directions for North Central Healthcare. Clearly, there's opportunities in the budget. There's recommendations that are being circulated that we are well positioned for. But what we're trying to do is above and beyond that. We are just about to start our phase 3 renovations on our campus that will completely renovate our inpatient psychiatric hospital, provide a 5-bed detoxification program and on an inpatient basis, modernize and expand what we do around crisis assessment and stabilization, and then provide 40 residential treatment beds. That program, those programs will all be constructed over the next year and open by the second quarter of next year. When we have those available, we'll have a full psychiatric ED, which will have physicians available through telehealth, 24 hours a day in a partnership or with another facility. And we hope to get to that 80+% of medical stabilities on site. We think we can do that with the telehealth presence of a physician and having a nurse available 24 hours a day to do some of the vitals and the initial evaluation. The second is a report that you should expect to see in the next month. We had started some work with a firm called the Human Services Research Institute out of Massachusetts. They did similar work for Milwaukee. And essentially what we were trying to do is look at the programs that we offer here today and look at best practices and design for our community what a modern and effective mental health system looks like. North Central Healthcare can't be everything and everything to everybody, to everything and everybody. But we are a very important backbone, clearly, in the emergency crisis services, but how we connect with the community and how we continue to design our mental health system is going to have a path forward here when that report becomes available here in the next several weeks. In terms of the future of addiction services, not only is addiction not prominent in emergency crisis services, but it's not prominent in our continuum of care. We have a very wide continuum of care for adults and mental health. We're building that out for youth. But as it relates to addiction services, up until a couple of years ago, we had outpatient services. To truly get to a full continuum of addiction care in our organization and be able to offer on-demand services for that person that walks up to our crisis services, we will have the 5-bed inpatient detoxification program, the 40 beds of residential treatment, from there intensive outpatient, day treatment, and outpatient. So really, truly a full continuum of care of addiction services that should be available no longer than a year from now, and that will come in phases. And then last but not least is really the part that I'm most interested in, and that's beyond linkage and follow-up, and that's all the time, every day in our community, we have family members that are just dealing with a mental illness or an addiction for the first time. And North Central Healthcare, when they engage with the organization today, it's, I think I need that service. I'm here because I think I need this. I'm told I need to come here for that. What we need to be able to offer to our community is much broader than that, which is helping people navigate the mental health system. It is very challenging and difficult for a family member who's dealing with somebody in crisis. The family is in crisis as much as the individual that we're dealing with. And to have somebody in a team that can help them navigate the system is incredibly important. Above and beyond that, in emergency services, we need what's called or referred to as targeted case management. And this is specifically for our individuals that are under commitment and settlement agreements. We need a team of case managers that are concentrated and focused that can actively work with those individuals to remain successfully independent and out in the community. We're doing that too decentralized today. And that causes high variability in the interactions that we have with those individuals. So I think those two things are the most important to me that we solve in the next couple of years to be able to really build this program and services out in addition to the facilities and all the programming that we're trying to offer in the future. But clearly, law enforcement is a key partner of ours. They are involved in our everyday interactions. I have both the chief of police sitting behind me and the chief deputy from the sheriff's department. Both sit on my board, and both are very involved and invested in doing all the work that I've went through in the last 45 minutes or so about what we're trying to accomplish, what we have to do statutorily, and certainly what we're trying to strive for. So I'd be happy to answer any questions about anything I covered today.
Are there any questions from the commission members or task force? I think you did a very, very good job. I think the takeaways are, I think that we've got some opportunities to evaluate and make recommendations relative to the CART expansion and support for the development and the implementation of the other services. I think that we'll probably revisit many of those points in the context of when we make recommendations to the community, whether it's the Police and Fire Commission or the City Council or others, or the department. But I think you gave us a lot of information. Ben, is there anything that, from your perspective, you'd like to comment on relative to the presentation tonight?
No, I can cover it there.
Other, Pat?
Yeah, I did have a question. Michael, you talked about the things that you'd like to improve on, and I'm wondering if you can do those things within the physical structure you have now, or if you're going to be doing those things, you're going to be having to change your building around or move people, or just, if it's just a matter of who's doing what when.
Yeah, all of these things in some form or another were a part of the vision that we cast in 2017 when we did the original design. We've made some tweaks to it. Ultimately, if the state budget is approved and there's additional funding available, and there's obligations that come with that we currently didn't invest in, the way that we designed our next phase, we'll have about 8 months before we could modify that design to maybe add a little bit to the back side of our campus, to expand a little bit more, to do a little bit more, but we're going to have probably the most comprehensive crisis services in the state when it's all said and done.
I'd like to point out that item 5 on the agenda is discussion and possible action in support of state budget crisis initiatives, is an opportunity for this group to weigh in and make a recommendation to our legislators to hopefully garner funding for some of these very important programs that have been outlined tonight. So we'll, without objection, I think I'd like to just jump to those.
Sure.
If we could. Is there an objection with jumping to item 5? Why don't we go there? So do you want to pull that slide up again?
Yep. Yeah, so there are 3 main ones. There are several others that are beneficial to North Central Healthcare, but primarily related to what we covered tonight. The first is the regional crisis centers. Again, this is $12.6 million in funding, 2 new regional crisis centers. Now, the term new might preclude us from this funding, but again, the devil's in the details of what's going to actually come out. We would be in a very good position, but clearly this is best practice and what a lot of communities need, and certainly what we would like to capitalize on. So we're very much in support of this provision. Let me keep going.
Please.
The Regional Crisis Stabilization Facility. Essentially, this will fund 5 new stabilization facilities in the state. Now, that same group that I referenced before with recommendations has actually come out with a modified recommendation relative to the state budget that they would actually like to see 5 state-owned or contracted hospitals. So essentially, they would like to deinstitutionalize Winnebago, which is the State Institute for Civil Commitments, and do that in 5 regional sites. The state institutes would be available for forensic or long-term civil commitments, but any short-term civil commitments would go to one of the 5 regional sites. Wausau is identified on that, so whether it's this provision in the state budget or the modified one that is ultimately adopted, both would put North Central Healthcare on the map, if you will, and being able to receive that funding. The modified provision takes us from $5 million to $100 million. And so that is going to be interesting to watch. That just came out recently, and those same groups that were pushing these recommendations are really behind that provision. So, but this one in of itself is certainly a strong recommendation as well. And then the third is around the CIT training. And again, this is critical. There needs to be more funding for CART teams as well, but for right now, crisis and intervention training certainly would be welcome funding as well.
All right. Any questions of Michael on the relevance of those to our efforts here? In light of where we are, Mayor, do you think there's any problem with us taking a position and making a recommendation of support for those 3 initiatives?
I think that would be just fine. And I will be proud to present them to probably our finance committee.
So is there any discussion or motions?
I'll make a, I'll make a first motion to support state budget initiative.
All 3? Okay. So is there a second? Seconded. So there is a motion, and I will embellish that for clarity. to support funding for the regional crisis centers, regional crisis stabilization facilities, and the collaboration with law enforcement contained in the budget. Is that is your motion?
Yes, thank you.
And your second? Any discussion on that? If not, all those in favor of adopting the motion of supporting those provisions will signify by saying aye.
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 Opposed, no. That motion carries unanimously. Are there any other questions for Michael at this time? Excellent presentation. Thank you for that overview and setting the context for some of those critical issues. And I'm sure we will be calling on you again. Okay. Then we'll jump back to item 4. And Eric, are you still with us? So we lost Eric, and I apologize. We had a faux pas on the calendar. So when we're talking about future items, one of those items is we'll be talking about the policing survey. And Jane had given you tonight the Wausau Policing Community Perspectives. If you could take a look at this draft, provide comments to Eric. We will then come back. We'll have time at our next meeting to go through this. But did he capture what we talked about at the last meeting? We can't discuss it tonight, but if you could take a look at that and make those comments to Eric, that would be appreciated. Perhaps if they'll make the comments to Eric, and then we'll at our next meeting sit down with his cohorts and try to finalize that. The step would be for us to finalize that, then to take it out to representatives from in the community to make sure that we've got the questions right, which will include representatives from the police department and others in the system before we finalize it and then send it out in June. But at our next meeting, we will try to, as near as we can, finalize the community perceptions survey. Are there any questions relative to that? Then one of the other items that I'd like to bring up in the near future is that I provided Ben earlier today a compilation of all of the policing recommendations that have been presented by the President's Commission on 21st Century Policing, the Wisconsin Professional Police Association's A Blueprint for Change, and the Speaker's Task Force on Racial Equity, I think, or whatever, the subcommittee relative to law enforcement. What we intend to do is look at all of those recommendations, determine which of them are appropriate for us to review to see if there is merit. In many of the cases, in fact, I was surprised that in a lot of the cases, Wausau is ahead of the game in terms of implementing them, such as the body cams, leadership, and a number of things. But what we'd like to do is use those as a baseline or a benchmark on which we can evaluate it to make sure that we can look at it. But I'm waiting for Ben to sort of look through the list, make sure we flag some are beyond our scope because they deal with federal funding or state funding that we don't control, but there will be opportunities. So later this week, we will send that out to you to begin to look at, so we can begin to, we'll group those into various categories. There were the 6 pillars that were in the in the President's Commission's report. I think we'll build off of those 6 pillars just for consistency. And we'll begin to try to look at which of those should be recommendations from this task force going forward. So look for that. And the final area is the use of force training. The chief and others in the department have strongly suggested that we as a task force go through training on use of force, which would require a dedicated meeting of 3-4 hours.
Yeah, I think 3 hours would be sufficient. We'll take as much time as you're willing to commit, but 3 hours would give us a good amount of time to be able to go through some dialogue, show some law, some case law, talk about those things, and then go through some use of force scenarios.
So do you have a preference if we do that at night, during the day, during the weekend, on a Saturday? Probably for you, it's probably easier during the week.
We are a 24/7 agency. We will meet the demands of your schedule, so we can do it whenever is convenient for the task force.
So I'm going to look for those people that are gainfully employed versus us retired people who are ungainfully employed. What would be your preference?
I think mine would be either in the evening or weekend, because then I know for sure I just have that time. If not, then I may have to just take off, I guess, but I'll make it, but.
If we were to do a
Preference.
5:30, it's harder and harder the closer we get to summer to do a Saturday. So if we were to do a 5:30 with the thought that we'd be done at 8:30, would that be something we could do? Do you know, are there some good dates, bad dates?
Whatever's convenient for the task force, we will make that work.
Where would we need to do this, at PD or?
Yeah, we'd probably have to be at the police department, so. But we can figure out we have room, so.
Why don't we do this? Ben, you and I can talk tomorrow. Let's send out a doodle poll specific to this.
Okay.
Once we've got some dates from him and see what works. Because we've got 2 members that are not here, and I think it's critical that all members participate in this. And along those lines, I'd like to also again restate that they're doing the ride-alongs. And suggest that if you're interested, you look at that. But we'll do a doodle survey relative to your availability for that. And that will be a dedicated meeting exclusive to the use of force training. We then need to pick our next meeting date. And that would be on the survey. I'm looking at the week of the 24th.
Health and safety is in here that Monday night.
County Board is that Tuesday, Wednesday, the 26th.
That would be fine in here.
Or how about, should we, I'm looking at trying to accommodate the schedule. Ben or Katie, do you remember when he wanted to roll that out? I gotta dig that up. Do you have that handy? I'm wondering if we should shoot for next week, Wednesday, if that's too soon. I think he would be ready, but I think that would give them time.
It looks like he wants to finalize the survey May 24th.
So how would you be on the 19th at 6:30?
I think if we got all of our suggestions on the survey to Eric, if he could have it ready by then, that'd get things going.
So I'm suggesting we look at the 19th and we get the comments, and then he wants to take it out to others, so I think he wanted just one opportunity to get the group together before he finalized it. So would the 19th work for a meeting?
And that would be at 6:30?
6:30.
That'll work for me.
All right. The day works for me. It looks like there's a Board of Zoning Appeals scheduled, but it says 4 to 5, so we might be okay in here.
Okay.
On the council, it
Would they be in the boardroom or here?
And it says here that it's gonna be in the council chambers, but, yeah. I feel
So
like
let's plan on the 19th here. We'll do the doodle poll for the use of force training, and we'll base it on that. So Ben, maybe you and I can talk tomorrow morning
Sure.
and look at some dates. You have access to the mayor's calendar?
I can busy search it.
We're going to control your
Yay.
life. Anything else that you'd like to see at a future meeting? Anything else? If not, Michael, again, thank you for that excellent presentation. Will those slides be available? If you could get them to Jean. She's the gatekeeper, and then we'll have them. All right, and we will need to do a WebEx for the next meeting as well, given the fact that we've got people across the state. So we'll, and if we could make sure we get them plugged in early. Anything else? If not, we are adjourned. Thank you.